Hi, everybody. We're just going to wait a few minutes to give everybody an opportunity to join us, and we'll start, right around 7. So if you're there, just if you can't hear me, we'll kind of use this as a sound check. So I'll be happy to see your comments. I'll try to answer as many questions as I can in the time that we have. But we'll give it a few minutes and let people join in. This is great. I see a lot of people coming into the room. Some names that I recognize. Some of you I've spoken to recently, so that's good. Let's see here. So we'll give it a few minutes, but my name is Jess, and we'll be talking about embryo grading. So hopefully everybody's joining the right room. Kind of new to this Instagram live, so just let me know if you can't hear me or if anything seems wacky. I am not the IT department, so we want to make sure this goes smoothly. So I hope everybody's enjoying National Infertility Week. Resolve started this week as a week to recognize all the features of infertility, the advances that are being made, the different support groups that are available to our patients. So it's an honor to be taking part in this week with one of our episodes in our series. I think Boston IVF does a great job of trying to keep our patients informed of everything that's happening. Glad to see so many people coming in. We'll give it a couple more minutes. We're scheduled to start at 7. Hopefully I'll be able to address some of the questions some of you have about embryo grading as we go through. Even if you have questions unrelated to embryo grading as we're going along, feel free to add the questions there. If there's time at the end, we can certainly try to address them. If not, we can always try to get back to you as well. We do a great job of going back through the comments, make sure we're addressing your questions. You'll get an email or a call back from us if we have that information available. Oh, I see that somebody's having their egg retrieval this week. So hopefully the grading will make sense for you to see when we're telling you what we found in the lab, what all that means. We had somebody who just had an egg retrieval yesterday. Congratulations. So you get your FERT check call today. So you'll get to find out, you found out how many eggs were retrieved, how many of those were mature, how many fertilized, and now they'll get to the point where they'll start growing and we'll be able to actually grade them. So we'll go over a little bit of that too, of how the flow works going through the lab. Love seeing these comments. Love seeing so many people coming in. I hope some of you were able to catch Dr. Baer and Dr. DiGirolamo earlier this week. They talked about some different features. I think Dr. Baer went over some tips on what it is like going through fertility and how our practice is set up to treat you. And I think Dr. DiGirolamo was able to give you some tips on how to get started, how to transition from trying on your own to seeing your OBGYN and then coming to see a fertility specialist. So those are some great ways to get started as well. I think those are archived on our Instagram page. All right, it's 7 o'clock, so we'll just give it one more minute. See, somebody has some embryos frozen, and those grades are always available to you. Feel free to give us a call if you want to go over more of those. If you have any questions after today, we can definitely go over and see what we have for you. Yes, we will be saving this Instagram Live. It should be posted to our page. It's usually there within the next day. I think they edit it and clean it up so that we were able to address any additional questions in the comments for you, but that should be available saved as well. And that way, if you feel like you missed anything, you can always go back. All right, well, it's 7 o'clock, so why don't we get started so that we can get through as much as we possibly can. My name is Jess Bailey. I'm the Chief Cryobiologist and Tissue Bank Director at Boston IVF. So I'm one of the embryologists. I'm one of the people that's in the lab that are collecting the eggs that the physician retrieves during retrieval. We collect them, go ahead and fertilize them and culture them through the lab to a point where we're either freezing them, biopsying them, transferring them, or combining some of that all together for you. And in the process, we need to grade those embryos so that we can differentiate which ones we feel like are going to become pregnancies and which ones are not. And so when we're selecting that one embryo for your transfer or trying to put them in order of the best one to go to next, we have a cascade to look at and see what's going to be best for that. Before we get into grading, I think it's really important to emphasize that every program, every embryology program is going to have their own grading system. And it's really important when you're comparing what your grading is to somebody else who's at another program that you really define the units. What is the system that they are using to grade their embryos? At Boston IVF, we use the standard Gardner grading scale, which is pretty popular. It's kind of an industry standard that looks at the embryos in day 3 and day 5, 6, 7, which are your blastocysts, in a very concrete way. Most of the time, we are talking about blastocysts, where you've already had cellular differentiation. We'll go over that a little bit more in a minute. But other programs may use a modified version of that, or they may have a completely their own version altogether. There are some programs that will use a standard that's used by SART, which is a entity that we all report to for statistics, so that we can compare how we're doing to each other and kind of keep industry standards at a basic level. Other places use their own. There's another facility in Massachusetts that has a grading system that goes all the way up to 9, whereas the gardening system only goes to 6. So it's really important that you know what system you're using, because if I tell you that you have a 3BB at Boston IVF, that may not mean the same thing as somebody who has a 3BB at a facility across town or in Middle America or all the way out into California. Every program needs to let you know what their grading system is and how that translates, what that language means when they say, I have a 3BB. The other thing is when you're doing grading, you have to know what day your embryo is, whether you're looking at a cleaved embryo, which is typically day 3, or a blastocyst, which would be day 5, 6, and 7. So the terminology that you use for those two systems on the age of the embryo is going to be very different. I'm going to attempt to share a picture. If for some reason we get booted off, I will certainly go right back in. But this is an example of a day 3 embryo. Hopefully everybody can see this. This is typically what we want to see on day 3. So if we go over the anatomy of this embryo, everybody can see there's a shell around the outside, that thick area around that is called the zona pellucida, and that is basically our eggshell. That's what we all start in. Eventually that eggshell is going to go away. It's going to thin out and it's going to crack open and the embryo will come out for implantation. But at this stage, we're going to see a nice thick zona pellucida surrounding those cells inside. So this 8-cell embryo that we would see on day 3, you can see all the cells are pretty uniform in size, and that's what we'd like to see. At this stage, we start your grading with how many cells it is. So this would be an 8-cell embryo. And then we grade at Boston IVF on an A-B-C scale, looking at how many fragments are in the embryo. So for this embryo, this is a pristine embryo. We don't have any fragmentation that forms, which would be little blebs of smaller cells and debris in the PVS, in that space that is between the cells themselves and that zona pellucida. It's filling in all that free space. Those fragments can come from a number of places. Probably most commonly, it comes from autocorrection. Our bodies are made to correct themselves. So if there's any errors in the DNA will start correcting itself and it will spit out those errors and making itself correct. There's going to be some metabolism, and that metabolism creates waste. And as that waste is dispersed, you're going to get those as fragments as well. So this embryo would be an A-grade embryo because we don't see any fragments. If we have between 5 and 20% of fragmentation there, then we'd call it a B. And those are still great embryos. Both A and B embryos are what we considered high implantation potential embryos. And sometimes you'll hear us use the word HIP, and that's what we're talking about there. They are really good quality embryos at this stage. If you're between 20% and 50%, then we'd be looking at a C grade embryo, and we can still transfer those embryos. They tend to have a slightly lower rate of implantation, but they are still completely suitable for transfer, and we do have lots of pregnancies from those. Once you get over 50% fragmentation, where you're having more fragmentation than embryo present, those embryos generally are not viable, and typically we don't recommend transferring them. But most of the time, this is what we're seeing in a good quality embryo. Most of the time in 2022, we're not even evaluating these embryos. If you are somebody who's going to be having PGT or only a blastocyst transfer, we don't even look at embryos in the Cleave stage anymore. So really, you're only going to be able to get this grading of your day 3 embryo if you're somebody who's come into your cycle with the expectation of having a day 3 transfer. Otherwise, you won't get this information because we want to leave it in the incubator and let it grow without us interfering. So we'll do your FERT check, it'll stay in the dish, and we won't pull it back out until day 5. We're hopefully we're seeing a blastocyst. And I'm going to try this again. And so if you can see this photo here that we've just switched over to, this is now what we would call a blastocyst. It looks completely different. This would be what we would expect to see on either day 5, 6, or 7. And it doesn't matter which day that happens. All embryos are going to grow at their own rate, just like if they become a pregnancy and result in the birth of a child, those children are all going to grow at their own rate. They all catch up. It's not an issue if you have a day 5 embryo versus a day 6 embryo. When you come back for your frozen embryo transfer, the body's going to accept them all as if they're day 5 embryos. It kind of gets a chance to reset. So that is not a concern in any way. But let's look at a couple features of how this is now different. So at this stage, we can see that zona pellucida, the eggshell, has gotten very thin. In fact, if you look down at about 5 o'clock, you can see that the cells are already starting to hatch out, and that's why you see that blebbing in that area, that the zona has now created a crack in it, and the embryo is going to start coming out at that point where that hole is. We have 2 different cell types in this now in this embryo. There's no longer all the same. What we need to see is the 2 cell types coming for differentiation. So in the Cleave stage, all the cells were exactly the same. They were all functioning the same. The DNA was written the same. Once we get to this stage, we're differentiating into 2 different cell types, and that's what you see here. So along the outside, you see that bubbling, the cobblestone-like feature of those cells. And those kind of create a bubble wrap, as Marsha Foreman would say at our Albany lab, to protect the embryo. They're ultimately what become the placenta, and those are trophectoderm cells. And then in the center there, you can see this gathering of cells all kind of poked down together. Those are what we call the inner cell mass, and those cells are what will become the fetus and the baby in the pregnancy later. So we need to grade both those cells. So again, we use the Gardner scale at Boston IVF, and we use 3 parts when we're doing that grading. The first part is a number, and that number is going to talk about the expansion. So if you remember back to the cellular embryo I showed you, you could see those 8 cells. Around day 4, they completely compact down and can become a complete mushy mess, and that's what we call a morula. You can no longer see the cellular divisions, but there's nothing really happening yet. It's just really a mushy mess. All the cells are kind of impacted together. They're probably about 125 cells, but you can't really count them because they're all melded together. Shortly after, as the differentiation starts to occur, we'll start to see a fluid-filled sac to come in, and that's what we call the blastocele. As that blastocele is coming in, and we begin to see it, and it's still taking up less than half of the embryo, we would call that a grade 1. Once the blastocele expands and is taking up more than half the embryo, we move into grade 2. And those both, grades 1 and 2, make up our early blastocysts. There's no other cells fully defined yet for us to do any additional grading. So you would only get told that you have either a morula, a grade 1, or grade 2, and that would be the complete grading. As we move into a grade 3, we have a full fluid sac there. And we can see these 2 cell types that we can see in this photo here. We'll start to begin seeing cells that are inner cell mass and cells that are trophectoderm. At a grade 4, The zona will thin out like you see here. The embryo is a little bit bigger. The fluid is still taking up all that space. We can still see full trophectoderm to full ICM. And so now that's a 4. At 5, it's starting to hatch out. So this particular embryo that we have as an example on the screen is a 5. We know it's hatching out, so it's moved to the 5. And then our final stage is 6. And 6 is when it's completely left the zona behind, which is something that will happen either in the dish or it can happen after transfer in your body. All of us had to fully escape that zona pellucida in order to implant and become a pregnancy. So that's their first number, is how expanded is the embryo. It's not an issue if you're a 3 or you're a 4 or you're a 5. Your embryo is going to go through all of them. It's just a matter of where you were in your snapshot today when we looked at you. And once you get to that 3 stage, we can start considering you for freezing. So if you have a 3BB for transfer, it's okay. You don't have to concern that you didn't make it out to 5. If we hadn't done your transfer and we let it continue to grow in culture, we probably would kind of seen it gone out to a grade 5 or a 6. It's just a matter that we put it back, and that's just where it is. The next thing is we have 2 letters. So the first letter will be the grade for your inner cell mass, and the second one will be for your trophectoderm. In both cases, it's on an ABC scale. And the way we do that is we want to look at it and we start with B. A B is exactly what we'd expect to see. We want to see a good number of cells present. And then we want to kind of grade it from there. So as long as we're seeing a good number of cells present and they're organized, they're not everywhere, they're still forming the way they should, then you kind of evaluate, is it less than we expected or more than we expected? So if all those cells or what we expected, but then there seems to be even more of them and they're fully compacting down and being super organized in that one spot and has that full compaction, then we would upgrade that to an A. If it's disorganized or the cells are falling apart or there are very few cells present and it's not reaching our expectation of where it should be, then we would downgrade it to a C. C embryos can still be transferred and can still become pregnant, but we tend not to freeze C embryos because there's not very many present. They don't tend to react very well to the procedure. On the trophectoderm side, it's the same thing. We want to look at, is there a good number of cells surrounding the inner cell mass along that zona pellucida that is creating some cobbling like you see in this picture? If there is, then we would start with the B and we say, okay, it's meeting our expectations. And then we want to say, is it more cells? Is it exceeding our expectations? Is there many more cells? Is there tight cobbling everywhere? If it is exceeding, then we will upgrade it to an A. If it's very patchy, very few cells, the cells are disorganized, they're just not there yet, then that would be a C. It's very possible if you have a C on day 5 and we continue to culture as we do, that it can improve over time, and it's possible by the end of the time in the lab that you've reached a B or an A and we can freeze it. At Boston IVF, we don't freeze CC embryos because, again, there's too few cells in both the inner cell mass and the trophectoderm that we overall don't expect great results. And typically, if we see a C, it may be that those cells are not present at all, they're very few, or they could be falling apart and kind of just starting to become necrotic. Obviously, those are not embryos that are going to continue to thrive, and that is why you don't have them included. But both A and B grade embryos at both cell types have great expectations for implantation. I did see a couple questions here where somebody was asking about early blasts. Is a level 1 or 2 less likely to implant, become pregnant? If you're transferring fresh 1s and 2s, no, they do excellent. It's just we're catching them a little earlier, right? If you're having a transfer, we're selecting your embryo at the morning of day 5. So this is really the first early batch of the time that we will observe them. It's not uncommon for them to be early blasts, and we transfer those and they continue to develop in your body and they will implant, and your pregnancy test 10 days later still has an excellent chance of implanting. Now, for transferring a morula where it hasn't started to have that blastocele form, the implantation rate is a little bit lower, but it's not 0. I think it's about 20% lower, but we have such high implantation rates today, it's still worth doing the transfer. We do transfer morula better on day 5. We don't freeze grade 1 and 2 embryos because, again, there's not a whole lot of cells present, and we don't feel like they do as well. So we only freeze 3 BBs or better at the blastocyst stage. I do have a video I want to show you of these embryos growing through, and hopefully it'll bring together everything that I've explained to you. Oops, wrong one. Hold on. Let's So it's very quick, but you can see that it went from its single cell where we could see the pronuclear bodies of both, and now it's undergoing its cellular division. And there is a time lapse in the corner there going super fast. So we're at about 90 hours right now. So this would be the day 4 into 5, the differentiation, and the hatching out. I tried to slow this video down for Instagram, but it kept crashing it. So that was not going to work, but it'll go through one more time. One of the things hopefully you can notice is that the zona starts to thin out as the fluid fills in and the differentiation is occurring. So this is that moria, that mushy mess, the blastocele forming. It will pulse as it's expanding. So hopefully everybody could catch it. It's very quick. I will try to put I'll try to put a slowed down version of that in the comments later so that everybody can see that. Is it normal to have a level 1 on day 5? Yes, it's normal to have a grade 1. Absolutely. A combination of an A-B grade. So both, you're going to have a number and then 2 letters. So it's very common to have, say, a 3AB or a 5BA, and that's us telling you which grade, each part that we've graded. So again, the number is the expansion, the first letter is your ICM, and the second letter is your Trophectoderm. When we're selecting for a fresh transfer, we always go on the expansion first. We're trying to get the ones that are the fastest growing, that they're the most aggressive, the strongest, if you will. But when we're selecting for a thawing an embryo for transfer, we kind of take a different approach. We're going to grade the Trophectoderm first. So we're going to want to select those A Trophectoderms first because they have the strongest chance of implanting. And once it's implanted, your ICM of A's and B's are both going to grow. So you A, B, B, A, they're both excellent. You really can consider yourself having good embryos if you have A's and B's. Somebody asked, so is 5AA the best and 3 is the worst? No, your top grade would be a 6AA, where it's completely hatched out and you're exceeding the expectations of both the ICM and the Trophectoderm. And I would say your worst is necrotic, right? You can't get any worse than no longer viable. 3 is our earliest stage that we freeze, but is by no means a poor embryo. A 3 of both AA, AB, BA, BB are all good embryos, so you don't have to be concerned about that. Unless you have had your physician request an out-of-protocol freeze, meaning we have freezing embryos we wouldn't typically freeze, you can be sure that all the embryos we frozen are what we would consider good quality embryos. Somebody asked, are sixes transferred before 5s if all else equal? On a day 5 transfer, on a day 5 fresh transfer, we will always pick the most expanded embryo, as I said before. But frozen, it is very possible that we will select a 3AA before we select a 6BB. Occasionally, a physician will tell us specifically which embryo they want us to thaw based on a conversation with the patient that may not match the same quality cascade that we follow in the lab. Our quality cascade that we have chosen is based on our own statistics over thousands of cycles over the last 25 years. So we try to do everything very evidence-based. And so if you had a 3AA frozen and a 6BB, we would take the 3AA first. How can I improve my embryo quality? That one's a tough one because you don't always know where the source of your poor quality is, right? So if it's age-related infertility, meaning you have a high FSH and a low AMH, or you've had other indicators that you're reaching critical levels in your fertility, there may not be much you could do. It could just be that your poor quality is related to chromosomal issues due to aging. But there's certainly lots of things that you can do. And I know we've had a number of these kind of talks where we've had people on for wellness, going over general health issues. Stress is always a big one. So we offer a lot of mind-body connections at Boston IVF with acupuncture and different yogas and massage and support groups. All of those can have a great impact on how you're approaching it. Of course, always keeping a healthy diet and exercise. Overall, you're wanting to treat your body like you're already pregnant. Those should all have factors, but there's going to reach a point where there may not be something specific that you can do. is ICSI better than natural fertilization? ICSI is really to address male factor infertility. So we're doing ICSI on patients who have such a low, either a low sperm count or a history of a poor fertilization, that we're using the ICSI in order to increase the chances of having fertilized embryos to work with. So saying whether or not one is better than the other, statistically over time, if you were doing ICSI only for male factor and you're now able to overcome that factor, your fertilization rates should be about the same. If you're doing ICSI for other reasons, then I obviously can skew those outcomes, and maybe most of the time it's the same. So if you can maintain some of the naturalness that you would have having fertilization, I think that's always nice. But your doctor can certainly talk to you about the risk and benefits of doing ICSI versus a traditional fertilization. How important is embryo grading if PGT tested and normal? So once you have euploid embryos, known euploid embryos, obviously we're only going to select from those. Anything that's considered aneuploid is not considered transferable at this time. So we would only be selecting from those, but we would still select the best graded embryo down the list, right? We've overcome one hurdle of now knowing that this one should have a normal 46 complement chromosome set. So now we can go to the next level and just use the grading. Whereas without the PGT, we're using the grading, but we still don't know if it's chromosomally normal or not. So if you don't become pregnant in a couple cycles where you did not have PGT done, your doctor may recommend that you do what we call a Thaw-Biopsy-Refreeze, where we can thaw the embryos, biopsy them, refreeze them, and then when we get the results, we could do a frozen transfer with the euploid embryos. Getting my screen here. Let's just see if we're getting any more questions. Is there a correlation between the grade and the PGT results? Not really. I mean, you'd be surprised. There's been there's obviously a number of embryos that are beautiful 6AA embryos that can come back aneuploid. And that's the reason why it's an additional offering for patients who have had maybe a number of failed cycles where we've put back good quality embryos that have not resulted in a pregnancy. You definitely have a higher rate of euploid embryos among normally developing embryos that are reaching those milestones that we would expect with a good quality. You would, at the same time, you should have a higher number of aneuploid embryos of the poorer grades. So the embryos that we're seeing that are becoming necrotic or containing the C the C grading do have a higher rate of aneuploid. But if you're asking us to biopsy out of protocol and include some Cs, we'll still do that if it's possible. With a C trophectoderm, it may not be possible because we need to make sure after we remove cells for the biopsy, you still have enough cells to implant for a pregnancy. And as I just explained, C means too few cells. It's not meeting the expectation. So it may not be possible, but we always err on the side of getting information for the patient. So if you have an embryo that's in that range of a B, because you have to remember it's not a definitive number that we're looking at, right? You're going to have a range where you may be on the higher level of a B, or you could be a lower level of B approaching the C grade. We feel like you still have enough cells to biopsy, but you're on that lower side. In those cases, we may indicate that it was a borderline trophectoderm, and we definitely have a higher rate of aneuploidy amongst those embryos that are borderline, but it's not 100%. So if we feel like we can biopsy and freeze it for our patient waiting a result, we will definitely do that. I think the more opportunity that you have for euploid embryos, the better. Is it common for an embryo not to survive the thaw process? It depends how your embryo was frozen. The technology that we use in the lab is changing every day. Originally, we used a technology called slow freezing, where it was slowly over several hours, we would lower the temperature of those embryos until we could get to the freeze point and plunge into the liquid nitrogen. The survival rate was very low. So if you are somebody who has older embryos that were frozen in that technology, it's not going to be the same as it is today. Today, patients who have their embryos, their blastocysts vitrified, which is a flash fast freezing process, the survival rate for those is about 96%. So it's very high, but that means 4% of your embryos are not going to survive. And we don't really know why that is. We've just explained that we're only freezing good quality embryos. And it does happen. It happens 4% of the time, and we're thawing thousands of embryos, so you can imagine it does happen occasionally, and we really don't know why that is. There's not usually an explanation. Just the cells are just not viable at the end of the procedure. Hopefully that's not happening frequently. It should be 4% of the time. It's unfortunate for when it does happen to a patient. Hopefully they have another embryo to go to so that the cycle's not lost, but occasionally that can be the case. What about an 8AA? What is the scale being rated on? So I think I mentioned before, so somebody's asking about an 8AA. And again, you'd have to ask the program that you're treating with what their scale is. So there is a program in Massachusetts that goes up to 9. So this may be that program. So they would have to tell you specifically. I believe that their AA is still the same as what I explained in the Gardner, but their expansion has been kind of pared down a little bit more. So you'd have to ask that specific program what their grading system is. Most programs will provide their patients a copy of that grading system. We have that available. It's on our website. Your nursing team can give you a handout. You could always ask the lab. And when you're having your transfer and your doctor is going over the grade of the embryo that you have being transferred today, if you don't understand, you should ask. You should be active in your care, and nobody's going to be like, oh my gosh, why are you wasting my time? It's not like that. You should feel that you're getting all the information you need to be involved in your treatment. So if you don't feel like your grading has been fully explained to you, please ask your doctor. And you have an embryologist coming in the room as well. So if you feel like you need some reassurance as to what you're having transferred or what you still have in culture, they can certainly review that with you. That the time that you have in that room is yours, and you should use it so that you feel comfortable that you know exactly what's going on for you. Does freeze thawing affect the quality of the embryos? So with this flash freezing that we're doing, the vitrification, your result when you thaw should be exactly what it was when we froze it. You shouldn't really see any difference. It's very rare. If this embryo is going to survive, it should survive fully. It's not usually the case where you have the lysis. Like I said, 96% of them survive. And in the 4% that don't survive, it's typically a fully necrotic embryo. It's not, well, it's kind of there. It still has, like 60% of the embryo intact. It's not typically that case. Most of the time it's fully necrotic if it's not going to survive. Otherwise, it looks exactly like it did when we froze it. And we provide you a picture at transfer. So you should be able to see. So what happens when we're freezing the embryos, we actually collapse them to remove the fluid using a laser because the fluid is what causes damage. So we get that fluid to come out and it collapses down, it freezes, and then when we thaw it, it fully re-expands and it comes exactly back, and you can see those two cell types that we were talking about. And that's why your grade is the same pre and post thawing. Now, if you have several hours between the time that we thawed it and transfer, you may see some growth happening, right? If we thawed a 3 at 9 a.m. and you're not having your transfer until 2, it's possible you've had some additional expansion. Not always, but it's completely possible and normal. Does assisted hatching work? Yes, not everybody needs it. Hopefully your embryo is functioning the way it should, but occasionally there are patients who have a thicker zona present, that eggshell around, that doesn't seem to be thinning out. And if you don't thin out in a way that the embryo can escape, you're not going to result in a pregnancy. So if you're somebody that we're observing thicker zonas and you are not resulting in a positive pregnancy, we may have recommended to your physician that they consider assisted hatching in a future cycle. If you're a blastocyst and we can see that the zone is thinning out appropriately, it's really not needed at all. So, that's something you can discuss with your physician to see what the risk and benefits of assisted hatching are and whether or not you would benefit from that addition to your cycle. Let's see. Success rates for day 7 embryo. So we only transfer on day 5 for a fresh cycle, and that's because we need to have a synchronization between the grade of the stage of the embryo and the age of the uterine lining, right? So you ovulated or you've been taking progesterone, indicating a small implantation window. So we need to do the transfer on day 5 so that we're reaching that window. So in a frozen embryo cycle, we can thaw all day 5, 6, or 7 embryos and transfer in that new window that we've designated for you. So when we do that, both day 5 and 6 embryos are pretty high. There is a slight reduction in the success rates for day 7 embryos. So we don't choose them first. We will choose from the day 5 and 6 embryos first, looking at your Trophectoderm and ICM grades. And then once those are exhausted, we've used them, then we would go to the day 7 embryos. And again, the only exception would be if your physician gave the lab a specific order that they would like us to thaw. Someone was asking about acupuncture. You should definitely get in touch with your physician. They'll give you all the information about reaching out to the Mind and Body Center, and they can set it up. A lot of our patients will do, some pre-cycle sessions, and then a lot of our patients will do an acupuncture session immediately before and immediately after their transfer. And that seems to have some actual empirical data showing that it can definitely assist in your cycle. I don't know the IUI rates because we don't report those outcomes the same way we have to report your ART cycles. With IVF cycles, we're required to report all of those cycles to the government for SART. The CDC, they will publish an annual report on number of cases and the success and the different items that are being performed that year, but that is not the case with IUI. So your physician should be able to give you those statistics more accurately than I could. Somebody's asking, what does a higher median mean in the Petri dish? I'm not familiar with that being an issue. So regardless of the grade, as long as it's freezable embryo, so the 3BB or better, of euploid embryo, depending on some other factors, because obviously there's a lot of factors that go into your chance of success, it should be over 60%. In some cases it can be as high as 80%, but there's a lot of factors that go into that. So without knowing your specific case, it would be very difficult to give you a number, but your physician should be able to look at your factors and give you a very realistic expectation. When does the new thaw-freeze process start versus the old process? It's just a different method in doing that. So what we do today just takes a few minutes. So where before it would take hours to do that session, slowly lowering the temperature, now it's down to 15 minutes, moving it through the solutions and plunging it into the liquid nitrogen. So it's just a difference in that method. It's a higher concentration of sugar and a few other items in there that have allowed it to have that higher success rate. So there's really no difference in how the process itself, where it starts. We still have to remove the water, add a cryoprotectant, and get it into the liquid nitrogen. Let's see. Loving these questions, guys. Feel free to ask. Looks like somebody had success using the Mind Body Center. That's great to hear. They're a great program. They have lots to offer our patients. They have events for the staff all the time, which I always get excited about. I'm happy to go in and have an acupuncture session or some other event. They have different things that we can go in for that. Do we have to say in which untested embryos get transferred? So if you haven't had testing, we'll just use your grading system. So we would select AAs first and then go to BAs and then ABs and then your BBs. That's just standard for the untested embryos. Somebody asked, if the FET is unsuccessful, will the doctor make notes for future FETs? Yes, they'll review the cycle and see if there's any indications of where we can make improvements. Is there any flags in your cycle? Was there anything particular about the thaw event, your transfer, how long it took you to react to the estrogen or the progesterone? We want to make sure all those things are in line. If there's anywhere particular that we can see that we can make an improvement for you, we will. If you're having a number of unsuccessful cycles, then your doctor may recommend doing an ERA or other adjuncts to see where we could help improve your rates. Oh, great. Somebody's had 4 babies with us. That's amazing. All right. So we'll take a few more minutes if anybody has questions. Just want to remind everybody, this is the 3rd episode that we've done this week for National Infertility Week. So if you want to continue the series, tomorrow we'll have Dr. Murphy on for a little lunchtime break, doing a live Facebook and Zoom session for live Q&A. I think we are asking for RSVPs for that. So if that's something you're interested in and you want to participate, you should definitely reach out so that you can try to be involved in that. And then Friday, I think it's a little bit of patient sharing, which I think is great too. So if you have a story to share from your experience, we'd love for other people to hear it. So we've been doing, somebody wants to know, when did we change our freeze process? So we started vitrifying at the end of 2010, beginning of 2011, with our change in the freeze center. So our older embryos, we're talking pretty old now. So prior to 2010 are using the slow method. But when we thaw our embryos, we actually thaw them using the same procedure that we use for the vitrification warming, which seems to it does seem to have a little bit of improvement in the outcomes. It's certainly not 96%, but it's not down in the 30s, 40s either. It does seem to bring it up a little bit higher, which is nice. Traditionally, we had always said you can't improve upon the technology that was used, but we're finding that actually does help a little bit. Are modified natural cycles available for FET? Yes, you just need to discuss with your physician. There's lots of different protocols that can be used in your cycle, and your physician will have an idea what's going to work best for you. Some people use a program cycle, use an estrogen, different antagonists present. Some are doing a fully natural cycle where you're just waiting for your natural surge. Some are doing a modified stimulated cycle where you may be getting some maybe some Clomid or cyclomonadotropins, and you're having a little bit of monitoring there. There's lots of different methods and different pathways to get to the point where you would have your transfer. So you should definitely discuss with your physician what treatment would be best for you. Somebody's going to come in on Friday. That's great. I recognize your name there. I have you all set up to go. We start thawing when we come in the morning, starting with our first patient at 7. And just kind of work our way through them. So if you're at 10:45, depending on how many we have to do on Friday, you'll probably be thawed, by 9 o'clock. It just depends. It depends on how busy the day is, how many thaws we're doing, as to how quickly we go through them. But we start our day at 7, where we get the liquid nitrogen out. All our medias are ready, getting ready to go. And as soon as everything's set up, we start with that first patient and then just go through one patient at a time. So it'll be thawed plenty of time before you arrive. What do we do with the embryos that fail after PGT-A? I'm guessing this question is related to what do we do with the aneuploid embryos, and it depends what kind of treatment you had. Patients have a discussion with their physician on what their dispositions will be at the end of their cycles. If you've decided to keep those embryos in storage, then you would need to complete a discard consent, a notarized discard consent for us to handle that. Is there a certain amount of time that you may begin to see deterioration of the frozen eggs? We haven't seen that yet. Theoretically, they should be suspended in time indefinitely in the liquid nitrogen. So as long as they've been in the freezer system untouched, they should retain whatever quality they had when you froze them. Now, not all eggs that we freeze are good quality eggs. So we don't have that same grading system for eggs that we do for embryos. So even poor or fair embryos, if they are viable, they're alive, they haven't been necrotic or don't show any signs of being fully abnormal, meaning they're not full of vacuoles or misshapen or have anything that's red flagging them as abnormal, they get frozen. And we may have to make notes on the reports that they're not good quality, so that your physician can set you expectations for your thaw. But you shouldn't see a deterioration over time. We've thawed eggs recently that we froze back in 2012, 2013, and they did fine. Your bigger indicator is going to be what kind of quality of eggs you froze. Were you a younger patient with normal parameters? Were you an older patient with poorer parameters? Or even a younger patient with poorer parameters? If you were already kind of near the tail end of your fertility workup, meaning that you had maybe a very low AMH or a very high FSH, the overall quality of the total cohort, meaning you may have more eggs that don't do as well versus them all doing well. And that, that's kind of the same in line as with your fresh eggs. You start out with retrieval with 15 eggs, maybe 12 are mature, and from the 12, maybe 10 of them fertilize, and maybe 6 of them become blastocysts, right? So you're going to see the same thing happen with the eggs. They may all thaw, and you'll have the same regression in growth over time. How does low motility affect the sperm? If motility is just the issue, we should be able to overcome that with ICSI. So if you have a male factor, we should be able to get it to fertilize. As far as the development of the embryo, it does make up half of an embryo, right? You're half egg, half sperm. So depending on genetic features, etc., it may have some effect to that process. There's really not much we can do if it has other genetic issues. Oh, good. So there should be a link in our bio for the RSVP if you're interested in doing that. I did see that here. All right. Well, I'm hoping I got everybody's questions. I'm scrolling through to see if I missed any, just to make sure that I'm trying to get to all of you. Somebody's asking about miscarriage, which week is most common. I'd have to refer you to your physician for that one. Miscarriages happen, throughout the first trimester, and I do not want to misquote which week would be the most common. Early ones are super common. If you don't make it to ultrasound, if you don't make it that far, that's usually what we consider a biochemical pregnancy. And then as you move on, whether or not you reach to heartbeat, those have different definitions. Your physician should be able to review that more clearly with you. Well, I want to let everybody know how much I appreciate that you all came on today. I hope I was able to answer all your questions. Somebody asked if we were able to do genetic testing on already frozen embryos. Yes, I did go over a little bit about our Thaw-Biopsy-Refreeze Program, so that is available to you. The important thing to remember about that is that not all the embryos that we thaw may be possible to be biopsied, right? So even though they would thaw and they do well in order to be transferred, they have to continue to develop and give us cells that we can actually biopsy all. So that is one of the risks, and your physicians can go over the risk and benefits of doing what we call the TBR cycle. There may be some loss in the overall number of embryos you have available. So not for everybody. You should definitely discuss that option with your patient so that you're fully informed on the positives and the negatives of that. All right. So again, thank you everybody for joining on. If there's any questions you have that we weren't able to get to, please put it into the comments and we'll try to get back to you. I'll try to get some more pictures up if anybody needs those to show the differences between the day 3 grades and the blastocyst grades, and we'll try to put a slowed down version of that video available so you can see the growth of the embryo as well. The video itself was a little fast, but to get the slowed down, you'll get to see the 2 pronuclear bodies that are present when we indicate fertilization, one from the egg, one from the sperm. We don't know which one's which, but as long as they're both there, we know it's a normally fertilized embryo, and then you can watch that development as it goes through those cellular stages, the morula, and then differentiation through blastocyst, and you can begin to see it hatch out. The embryo does abruptly disappear because this is an embryo that we transferred, and I did look back, and it looks like this was actually delivered as a healthy male. So you can go through that whole video and see how that works. If you have any other questions, let us know. But we hope that we'll see you with Dr. Murphy tomorrow. And I hope everybody has a good night.